In this video, we will discuss about how I do occlusal examination. However, before you understand how to do occlusal examination, you need to know when to do occlusal examination. In my opinion, all patients, all new patients, you need to do occlusal examination to assess any untoward issues you can have in future. However, if you really want to pinpoint when you really need to do occlusal examination, then in my opinion, when you see signs and symptoms of parafunction, that's the time when you really need to make sure that you've done thorough occlusal examination. So what are the signs and symptoms of parafunction? So when you're looking at temporomandibular joint, you might find that the patient comes with pain or limited or irregular movement. If you're looking at the muscle, again, patient might come with the pain or myospasm. If you're looking at teeth, then you can see varefacetting, drifting, fracture, pain, hypersensitivity with the teeth, and these becomes more and more common as you see patients for often. If you're looking at the restoration, then patient can show signs and symptoms of wear on the restoration, fracture of the restoration, or delamination or debonding of your newly restored teeth. Now, all these signs and symptoms you come across when you're doing in-depth clinical examination. However, what are the telltale signs? You can just look at the patient and say, look, I really need to look into it in more detail. So I call them warning signs. So one of the warning signs is patient comes to you and you ask patient to close their teeth to check their minimal maximum intercuspation, and patient cannot really close their teeth properly. If that happens, or if they're taking longer time, or if they're closing in two completely different positions, then you need to really see why these things happening. It could be that their muscles are affected, that TMJs affected, or it could be that they just don't have a stable bite. The other time you see patients when they're having multiple broken teeth. Now, there could be multiple reasons of breaking teeth. However, if you see many broken teeth in one patient, then you need to really make sure that you do occlusal assessment, especially if you're planning to treat those broken teeth. The third thing, when patient comes with pain near the TMJ joint, that's another reason to do proper occlusal assessment and temporomandibular joint assessment. Now, as I said, I usually do occlusal examination along with my full clinical examination, which also includes soft tissue examination, periodontal health examination, cancer check, and all the different various examination which you would do for full clinical examination. However, in this video, we will concentrate on just occlusal examination. So when I'm doing occlusal examination, I'm looking at temporomandibular joint, clicking, crepitus, or any pain. Same thing with muscle mastication. If patient's having any pain during function or non-function of the muscle, I would then assess individual teeth for vitality, mobility, and prognosis by doing clinical assessment. It's very, very important to do this because it breaks down the treatment. And many times dentists approach me and say, oh, this case is very complex. And all I say is you need to make sure you break it down and it becomes easier. So if the mouth looks, a mess, start with one tooth. Start with that tooth, whether it's salvageable or you need to take it out. If the tooth needs to come out, you extract the tooth. If it needs to be saved, you can save the tooth and temporize it. And then once all the teeth are stabilized, then you can assess patient's occlusion and make sure you plan a proper treatment plan for then longevity of those teeth and restore the missing teeth as well. And obviously I do occlusal examination. Now, occlusal examination involves assessing their skeletal patterns, their type or class of occlusion. I assess their overjet and overbite. I assess their CO and their position in CO. I assess that MI position, and I assess their CO to MI slide, which could be large vertical, small horizontal, or small vertical, large horizontal, depending on how far forward the jaw goes when it slides and how far upward the jaw goes when it slides. So if you're going more forward than upward, then it's large horizontal, small vertical slide. If it's going more upward and less forward, then it's large vertical and small horizontal. And most of the patients fall into that category where jaw goes more upward than forward. But there is always a combination of both movement. I check a shim stock hold for each teeth to see using shim stock, not articulating paper, because articulating paper can be 12 to 24 micron thick, or sometimes it could be 200 micron thick, depending on which articulating paper you're using. Shim stock is around 8 micron thick, so you can really see which teeth are in actual contact. And I would record that. And more importantly, I will assess patient's guidance and any potential non-working side contacts, or some people call it interferences. So I would start with right lateral guidance. I would check teeth which are guiding on the right side, but also teeth which are guiding on the left side when patient moves on the right side. And the teeth which are guiding on the left side is called non-working side contacts. Similar to the left side, I would assess, and then when patient's protruding. So let's have a look at all the clinical assessment protocols and all the steps which I follow when I'm doing occlusal assessment in the following video. So first for any examination, we are going to start with extraoral examination. So we start with the palpation of the muscles of mastication. So we'll start with the temporalis muscle first. So if we feel the anterior head, is it painful, Holly, here?
Nope.
Okay. Any pain here?
Nope.
Okay. Any pain here?
Nope.
Any pain here?
Nope.
Perfect. Now, clench your teeth really hard. Is there any pain here?
No.
Clench it again. Any pain around this area?
Nope.
Perfect. Now we go through the masseter muscle. So again, if you can clench. Any pain around here?
No.
Keep clenching, yeah. Any pain around there?
Mm-mm.
Perfect. So you could use the masseter muscle examination by pinching. So open big and slowly close and clench again. Any pain around here?
No.
Perfect.
Oh, that bit there.
Yeah, open, close again. Here?
Mm.
Okay, so it looks like the superior head of masseter muscle may be painful. So you're going to do the same thing on the other side. Clench again.
Mm.
Painful here as well. Okay, so the superior head of masseter muscle is painful there. Now we will check the medial pterygoid muscle. So if you can open your mouth, then you just you go inside the ramus, between the pterygoid raphe, and then you press it around the ramus. Is it painful around here? Okay. Same thing on the other side. Is it painful around here? Okay. So that's fine. So the medial pterygoid is fine. That's all the examinations of the muscles is done. Apart from the superior head of the masseter muscle, there is no pain with any other muscle as far as we can see. The only muscle we haven't assessed is lateral pterygoid, which you cannot palpate physically. So the way we do that is ask patient to protrude against resistance. So if you move your lower jaw forward, is it painful?
No.
Perfect. Close your teeth. Now move your jaw, open your mouth and see if it's painful.
No.
No pain. Okay. So there is no pain on moving forward or opening mouth. That means the lateral pterygoids are not stressed, or there is no pain with any lateral pterygoid muscle. So we're going to assess the TMJ and palpate that if there is any pain or crepitus or clicking. So I'm just going to put my finger around in front of your ear, Holly. Open your mouth and close. Open your mouth and close. Is there any pain around there when you're opening or closing? Okay, perfect. Open again and close. And we look for any deviation or deflection. So there is no deviation or deflection. So that's good. So now we're going to go with the intraoral examination. So when we're doing examination intraorally, I would check the intercuspation of the teeth to see how is it? Is it stable, or is there any instability? Here you can see there is a crossbite on the right hand side, and the left hand side there is no crossbite. Open your mouth and close, and it seems stable position when patient closes. Now we need to assess the vertical and horizontal. Can I have Williams probe, please? Vertical and horizontal overlap. So now we're going to measure interincisal distance. So open as wide as you can. That's 45 centimeters. That's normal. And close your teeth. So I'll measure the horizontal overlap by placing the probe, such as Williams probe, like that, and that's 3 millimeter. And then vertical overlap. Slowly open. Right down. Perfect. Then you can get 3 millimeter there overlap as well. So that's fine. With regards to overlap, when patient opens, open really wide. You can try and see if the mouth opening is limited. You can try and push it like that and try and feel that is there the end feeling, but it's really good opening here. So you don't need to, you can close your mouth, it's fine. You don't need to assess that. Now if you can just move your jaw forward, keep going forward, perfect. And you need to measure the distance from there. So it's 7 plus 3 millimeters, so it's a 10 millimeter protrusion because there was a 3 millimeter overbite already. Close your mouth. Now do right side, just extra excursion. Right side, move your jaw right. Keep moving as much as you can. Perfect. Here again, you have 4 millimeter with canine. Close your teeth, and then there are some overlap there. So that's somehow you measure, and then move on your left side. Keep moving as much as you can. There is a little bit restricted movement on the left, so close again. Perfect. And then that's the overlap, which is around nearly 4 millimeter. So 4 plus 3, so 7 millimeter is the lateral excursion. And then we assess the occlusal plane. So open again. So we check the occlusal plane on the upper. It looks pretty flat, so it's fine. Check the occlusal plane, the lower caudal spay, and it looks again pretty flat. So that's fine. On the right side, there is more steep curve than the left. And that could be because of the crossbite. Once that's assessed, we can then start assessing the shim-stock hole. So I'll start from the right hand side, open big, close your teeth. So that's holding, open again, close again, not completely, so you just open tiny bit so I can slide this through you. Close again. Perfect. So shim-stock holes is from upper right 7, lower right 7. Open again, close again. Upper right 4 and lower right 4. Slowly open, close again. Upper right 3, lower right 3, close, open, close, yeah. Upper right 2, lower right 2, open again, close. So centrals are really good actually, so it's holding just about, but I can slide the shim stock through, open again and close. And same thing with this one, open again, close again. Good, open again and close. So this is actually what you are trying to achieve in doing full mouth reconstruction. However, in canine it's not holding. So canine you want a bit more, close again. Yeah, so it's not holding, open again, close. 4 and 4 is holding, open again, close. That's not holding, open again and close. Open, close. So that's holding, open again. So if you have a shim stock hold on the left side 4 and 4, and then really right at the end 8 and 8. So those are the shim stock holds. Now we're going to mark the contact points. Black, please. You can change it to blue. So before we do that, we need to dry, open the surfaces. Suction. Close your teeth and tap, open. Close your teeth and tap, open. Close your teeth and tap, open. Okay, so that's the occlusal points. So you're going to check the right hand side excursions. So first we check the right side contact point. So close your teeth, tap tap, open. Close your teeth, left, tap tap, yeah, open. And anterior, close it again, tap tap. Close it again, completely. Back teeth now, perfect. So open again. So what happened was that when I was trying to ask to close, Holly was closing quite anteriorly, so I'll have to do that again. But that happens, so you need to make sure that you keep an eye on how patient's biting, otherwise you get different contacts which are not true. So can I have another paper, please? Cut slightly less next time. Just close your teeth. Oh, sorry. Close it again. Tap tap. Open. Close your teeth. Tap tap. Perfect. Open. Close your back teeth. Close your back teeth. Tap tap. Open. Open. Excellent. So now we have this markings. Now we're going to check for the guiding side. Okay. Yep. So again, when you're doing this, you need to ask patient to close again and tap tap. Perfect. Keep it closed now and grind your jaw towards my side. Right. Keep going. Keep going. Keep going. Keep going. Open. Perfect. Now you're trying to check the guidance. And you can see the canine is guiding, so close again. And this canine here and lateral incisor are guiding, so keep going right, slowly, so close your teeth, keep going right, slowly, and stop. And you can see that these two teeth are guiding, and that's where the green marks are, and that's where you can see the more rare facets. And that's mainly because, you can relax this side, that's mainly because, and close again, and grind it again slowly, and keep going, stop. You can see maybe right at the end here, the 7 distal of the 7 can get picked up by that, so open again. Let's check if we have a green mark there, and there is a tiny bit green mark, so let's check again if it gets a bit more better marking. Close your teeth, grind it towards my side, keep going, keep going, keep going. Okay, that's it. So the way we can sometimes check if it is guiding or not is close your teeth. Now ever so slowly grind on my side and stop. So the front 2 are in contact, but the second one is not, 7. So definitely these 2 teeth are in guidance. So that's the right hand side guidance. With regards to the left hand side non-working guidance, so close your teeth. Open. Yeah. Perfect. Close your teeth. Tap, tap. And then grind it my side. Yeah, keep going. And open. Perfect. So the reason we do to tap, tap is to make sure that we include the ICP. So all the markings which has a red and black overlapping, they are ICP marks, and if you see any slides, maybe here you can see a tiny bit, but I know from the ICP that there is an ICP mark on that tooth which is very heavy, so I'm not sure whether it's contacting. So let's check one more time with that. Close your teeth and slowly, gently grind a little bit on this side and stop, and it's not contacting. So we're not, even in slightest opening, that tooth is not in contact, so we know that there is no non-working side contact. Open again. Same thing with this tooth here. On the premolar, you can see maybe a little bit of smudge there. So you can check again. Close your teeth. Grind it towards slowly my side. Close back again. Grind it slowly and stop. Yeah, so there is no contact in there either. So open again. If you really want to be sure, you can, so close your teeth, tap, 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 open, and you can see all the red is covered by black. Maybe not the last one. Close your teeth, tap, 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 open. You can see just about there, the 8 is still tiny bit, there is a guidance there which I can see, so I'm just trying to see whether it's true. Close your teeth again, tap, 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 open. Yeah, no, I think it's covered as well, so there is no red mark on there. Close it again, tap, 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 open. Yeah. So there is no non-working side contact in this case. Okay, open again, close your teeth, tap, 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 open, close your teeth, tap, 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 open. So relax and close, tap, 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 open, perfect. So, and the black, and the green for it. Okay, so now we're doing a left side excursion, so close your teeth and tap, 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 open. I'm just checking, making sure that they are overlapping with the black, so that's fine. Close your teeth and now move on this side. Keep going and open. Okay, then I'll assess to see how it's looking. It looks like the lateral incisor, canine are guiding. And I just want to check with the black contact because they were almost gone. So let's check again. Close your teeth. Tap, tap, tap. Open. Okay. So now you can see. Close again. Open. So on the left as well, you have a canine and a little bit lateral incisor and maybe tiny bit of molar. So you're going to end up with premolar. So let's check again. So close your teeth again. And now just move your head jaws this way a little bit. Perfect. Now grind towards my side. Perfect. Go back again. Slowly grind. Keep going and stop. And you can see that there is a guidance here. This was just initial guidance and it's gone. There's still these two. There's no guidance with the posterior teeth. So keep going slowly again and stop. And you can see how flushly it fits into the facets. Keep going again. And you can see the faceting there. And now you can see this edge, how it merges there. Close again. And slowly grind towards stop. Okay. So you can see the initial guidance is also picked up from the premolar, but then it just discludes as soon as the canine and lateral incisor takes over. So that's that. And then we need to check on the opposing side. So close your teeth, tap tap again, and grind it towards this side. No. Open again. So again, it's same side, and we want to do that, so let's do that. Again, close your teeth, tap, 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 open, close it again, tap, tap, tap. Now this side, keep going, open again. So I can't see any excursion, so we check again. Close your teeth and slowly stop, open again, close your teeth. So I'm just checking the third molar. Again, go on the left again, slowly stop. So it's holding, the third molar is holding. So that means there is a guidance from the third molar. So open again. And you can see on the lingual cusp, it's causing that kind of guidance. So close again. Open. Close again. Grind it towards this side again. Yeah. Open. So I could see that there is a guidance there. So I'm just going to check with the ICP. Close your teeth. Tap, tap, tap. Open. And you can maybe see just a little bit on the 8. Can I have a suction, please? Okay. Yeah. Ready? Okay. So we're now going to check the protrusive movement. So first ICP again, close your teeth, tap tap, open, close your teeth, tap tap tap. You have to keep changing articulating paper, so relax again, close, tap tap tap, open, Okay, so you can see that apart from canine on the right, nothing else is much in contact in the anterior. So now we're going to check the protrusive guidance. So before we do that, we're going to tap, tap, tap. Now close and grind it forward. Keep going, keep going, keep going. Open. Okay. So what we see is that the canine is contacting, this canine is guiding more. You can see this line. You have all the incisor working as well. So let's just check whether it's true or not. So close again. Now open. Let's use this. It's easy to see. Close again. Now grind it slowly forward. Stop. So you can see that there is a deviation on the right hand side, and the canine is still in contact. Lateral incisor central, other central is in contact. The right lateral is just about in contact here and here, and then the canine is about to go out of contact. So carry on moving forward. Keep going, keep going. And you can see canine here is the most in contact, and then you have a lateral incisor there. Keep going forward, keep going forward, keep moving completely. Yeah. Keep going beyond that. Okay. So, and close again. Keep going forward, keep going completely, yeah, that's fine. Keep going forward. Now we are checking the faceting. So, keep grinding, keep grinding, keep going. And stop. Keep going forward. Okay. And you can see, stop, yeah. You can see the faceting here, and the faceting of these two is merges really aligned. So that means that there is a bruxism habit as well, because usually in natural position you would not move your jaw this far forward. So close your teeth again. Now we're going to check any posterior contacts. Open again. Oops, sorry, I moved it. Okay. Close. Grind it forward. Open. Close again. Grind it forward. Open. Okay, so you can see a little bit of contact on the premolar.
That's got it.
Yeah, so you can see a little bit of contact on the premolar, both premolars. On this side there is no much contact, so that's fine. So let's check again whether that's true contact or not. So close your teeth, grind it slowly forward, stop. Yeah, so you can see that this premolar is still in contact with the canine, and this premolar is contact with the upper premolar. So they both are guiding when patient's guiding forward. So that's a true contact along with the others. So that's what you can see how it works. So open again. And here on the 8, again its red mark is coinciding with the black, so we don't need to worry about it. I'm just going to check. You can see the wear facet on the both premolars, and we know that they are guiding lateral as well as now anterior protrusive movement, and that's why they are much wider faceting around there. There is a faceting or a lending facet around here as well. So you need to watch out for the faceting and the grooves and see why these are happening. And there is always a reason why certain facet is at a certain area. Most of the time it's either parafunctional or functional habit and the contact of the teeth. So one way you can check the guiding teeth are by using shim stock when patient's guiding on the opposing side, so or whichever side you want. So we know that lower right 8 or upper right 8 is in contact when patient's guiding on left, so there is a non-working side contact. But we want to confirm it because articulating paper thickness is 14 micron and this is 8 micron. So we just want to see we don't get false positive result. So we will check with the shim stock. So close your teeth on that. Perfect. So that holds. Now just slightly grind on this side. Keep moving on this side. Left side. Keep your jaw. Grind on the left side. Perfect. Keep going. Perfect. So it discludes very, very quickly. So open again. Close again. And slowly, tiny bit go on this. Perfect. So open again. Although we can see that there is a little bit holding, but it's between 8 to 14 micron. So the thickness. So because the shim stock discludes as soon as patient moves on the left. So close again. And very slowly, just tiny bit. Perfect. Yeah, it just discludes very, very quickly. So I wouldn't say it's a true non-working side contact. It's just the articulating paper. It's very close. That's why articulating paper is picking it up, because the thickness is between 8 to 14 micron, but below 8 micron, it's not holding. So there is no true contact per se. It doesn't mean that there is no contact at all, because when patients grinding or clenching in CO, you might get that contact, but definitely not in true lateral excursion. So that's one of the way you can check by using shim stock. We already discussed about opening and closing. So open your mouth and close. Open again, close. So there is a slight deflection on the right, and then the jaw goes comes back to normal. Deviation, and then comes back to its position. So when you have deviation or deflection, you need to note that in paper, and what I would suggest is you draw it in the paper, the amount of deviation or deflection in the case. Now we're going to check the CR, and this is the time where you can use 3 main methods. You can use just a bimanual manipulation, you can use a Lucia jig, which we'll show you later, and you can use a leaf gauge. Bimanual manipulation, so we'll discuss that first. You could use a single hand and bimanual manipulation. So we'll check with the bimanual, which is much more controlled. So what we need to do is make sure the chair is completely flat or slightly actually inclined backwards. So we're trying to use as much gravity as possible. Also ask patient to tilt the head up a bit. Perfect. So what happens is the mandible naturally falls down, and that helps you in guiding the jaw. As we discussed before, we don't really want to push the jaw far back too much, but you really want to guide it. So you need to have some sort of a pressure there to guide. So the way I would do it is you put your fingers right around on the mandible, not on the floor of the mouth, angle of the mandible, 3-finger front, little finger at the back, and then you can use your jaw, the thumbs, and what I would tend to do is I would use thumb right under the lateral incisor, and so that they're meeting like this. Okay, and then I would just open again and then gently close. I would avoid doing jiggling motion, so you want to really gently guide the patient into CR. So just gently close, slowly close. Let me close it here for you. Perfect. Tell me if you feel the first tooth in contact. Where does it hit first? Where do you feel first?
On this side.
On this side? Okay, perfect. Let's check again. Gently close. And stop when you feel the first contact. Is that what you're feeling? Huh? Yeah? Okay. So what you need is, we need a nurse to use your Yeah, black articulating paper. So just keep it on this side here. Okay, perfect. So just push it outwards so it doesn't hit the teeth. And then just relax again. Perfect. And then just stop and you feel the first contact, okay? Pull. Open. Open. Open your mouth. Perfect. Let's have a look. Where are we getting them? So I can see the palatal cusp of the 8. I can see there is a contact there now. But it could be a false contact. So I'm just going to wipe it and we're going to redo it just to make sure that we're getting that again. Same area. But usually if it's a distal most tooth, then that's the one where it contacts. So
I can't quite tell, but I don't know if
we'll
my
check
lower
both.
right
8
8,
yeah.
but I can't tell.
So we'll check both, that's fine. So sometimes it could be difficult to diagnose, so it's fine. So just push it outwards. So let's have a look. Just relax and close. Yeah. Open. Let's see. Yeah, it's the same tooth again, same cusp. Just checking whether is there any pre-mark beforehand. So if there is any marking, we just need to remove it, make sure there is no marking for the back teeth. Okay, so we're going to check on the right hand side. So yeah. Okay, perfect. Just relax and close. Very good. Cool. Open. Open right up. So we have a dot on the 8 as well, on this side as well. I don't know if you can see.
Hold it. I'll just
Zoom in.
try again.
So now we have 2 contacts and both are 8, so it could be any of them. So what we're trying to do is we're trying to find which contact is true. It could be both, but usually it's one contact, and it could be that the timing then they touch is very quick, and that's why we may not be able to differentiate, and we might have to use a mounted model to assess which teeth are in contact, which tooth is in contact first. But one of the way you can check is by using shimstock and using single-handed manipulation of the jaw. So the way we are doing is you'll ask nurse to hold on the left-hand side, and I will hold it on the right-hand side. And when patient feels that patient's touching the jaw, there, we will take it off, and then we'll see which one is contacting first. So just relax again. Yeah. And close slowly. Contacting. Yeah, so it's left hand side. So that's contacts first, which was the first one which Holly said. So the left looks like it's the first contact. It was pulling hard, isn't it? Okay. So let's check one more time, and I'll show you so this is a single-handed manipulation. So you really use the jaw and grip it, and then what I'm doing is I'm trying to guide it with a single hand. And using shimstock on one side, so okay, yeah, relax and then close slowly. Open. Relax again. Close. Yeah. Open. So that's holding there a little bit. Let's check this side. Relax again. Relaxing. And close. Open. So it's holding on this side right now. So just could be because it's 8, it's difficult to relax again. Close. Feel it's touching, yeah? To me it looks like it's the right side. What do you feel?
I don't know, they're both.
Yeah, a bit of both.
Sometimes it's the left, sometimes it's the right.
Yeah. So let's try again and then see this way. So open. Just relax again. Close. Right, isn't it? Yeah. I can feel it. Sometimes you can feel when the patient's contacting too, then you can feel with your fingers there is some contact. I could feel it right side this time. And Holly felt it right side. The other way to check is using leaf gauge. In patient's mouth, close again. That's fine, you can bite on it. Grind it forward and back. Just really checking how much opening there is. And I can see there is a fair amount of opening, so I'm going to reduce, open again. A few gauges. I'm going to go maybe 15. Close your teeth. Grind it forward and back. Okay. Any contact with the teeth? Open. Close your teeth. Grind it forward and back. And squeeze. Any contact with the teeth?
Right.
Right hand side? Okay. And none of the teeth are touching? Okay, open. So at 10, we're getting one tooth touch contacting, which is right side. No, that's 11, sorry. So this is number 12. Close your teeth. Grind it forward and back. And squeeze. Any contact? No. Maybe slightly on the right. Okay, open. Let's give me shim stop, please. So let's check now. Close your teeth. Grind it forward and back. Squeeze. Open again. Close your teeth, grind it forward and back, and squeeze. Yeah, so I can see it's touching there. Open again. And as we know that there was another tooth in question, so let's check that. Close your teeth, grind it forward and back, squeeze. Okay, so we know that I think it's the upper right 8, so keep it open. So the leaf gauge helps in checking that very, very quickly. So now what I'm going to do is I'm going to increase a couple of leaf gauges so that it's not in contact. So let's check again. Close your teeth, grind it forward and back and squeeze. Is there any contact? Still, yeah. Open, keep it open. So there was a contact with 14 as well, so I'm just going to increase 1. Close your teeth, grind it forward and back and squeeze. Any contact there? No. So there is no contact with 15. Let's check again. With 16 we increase a little bit more. Close your teeth, grind it forward and back and squeeze. No contact. Open again. Perfect. So now we're going to go back to 14 and just check whether there is any contact. Close your teeth, grind it forward and back, Squeeze. Any contact? There is, yeah. Perfect. So open again. So there is a contact with 14, but there is no contact with 16. Close it again. Grind it forward and back. Perfect. So that's the number we can check. And what we can do for your bite registration, if you want to do that, you can just check the distance, which looks like fair amount. There will be less distance at the 8, and that's what we want. We want the minimum distance, minimum opening. And squeeze again. You can't feel any. Are you feeling any pain when squeezing anywhere?
Right here.
Okay.
But I think that's on the muscle.
Muscle, you feel any muscle? Keep it open. It's the same pain where you had before when I pressed it.
Feels a little bit more further back, like in my ear.
Ear?
Yeah.
Okay, so that could be jaw. So on the left side, do you feel anything?
No.
Let's check again. Open. Close your teeth. Grind it forward and back. And just do gentle, just without any pressure. Does it hurt? No. Gentle pressure. Any pain?
I can feel it like
There.
it's right here.
There. Okay. Are you getting that? Yeah. So open. Close. Open. Close. Bite it. Is it painful then? No. Open again. Close your teeth. Grind it forward and back. Squeeze. Any pain?
Yeah.
Still pain. Okay. Open. So that could be two reasons. It could be in the capsule, in the TMJ because of the bruxism, or it could be tender muscle. So let's check one more thing. So if you can have a cotton wool rolls to keep it open. Close your teeth slowly. Open again. Close it again. And squeeze. Open. Close it again. And squeeze. Open. Keep it open, yeah. So what we're trying to do is we're trying to break the tension in the lateral pterygoid. So let's see if that works. So close again. Grind it forward and back. And squeeze. Is it any better? It is, yeah? Perfect. So now we know that it's the lateral pterygoid muscle which was painful rather than the TMJ itself. So which is understandable because of the parafunctional activity. The lateral pterygoid is firing all the time. So it's a very good trick with the cotton wool roll. What it does is it pushes, it just stretches the lateral pterygoid ever so bit more. And that helps in sort of deprogramming. So close again. Bite it. Squeeze. Open. Very good. Close again. Grind it forward and back. And squeeze. Is that okay? Perfect. So we just really relax the lateral pterygoid within 5 seconds. So open again. Keep it open. So that's the load test. So when you're doing load testing with a gentle pressure, if there is pain, then that usually is intracapsular. If it's a moderate or firm pressure pain, then you need to really see whether it's intracapsular or it's muscle-related pain. But we know from our muscle examination, when we were palpating, the masseter muscle was painful, and that suggests to me that it would be muscle pain. Now, once we have assessed that the upper right 8 is the first point of contact, now we want to check the slide, the movement of the slide. So this is where we can see whether it's large vertical and small horizontal, or small vertical and large horizontal, large vertical and small horizontal. So we're going to check, perfect. So we know that on 14, there was a contact. So let's go back there. Open, grind it forward and back. Do you feel contact there? Yeah, perfect. Open again. Let's check. So what I'm trying to do is mark that contact. So again, grind it forward and back. Squeeze. Perfect. Open. Keep it open now. Red. Close your teeth, grind it forward and back and squeeze. Perfect. Now gently open. Not completely. Close again, grind it forward and back and squeeze. Okay. Slightly open so I can slide this out. And close. Perfect. Open. So now we want to check if there is any slide. And you can see there is a...
Got those, yeah.
Yeah, perfect. Yeah, perfect. So there is a slide you can see from the cusp to fossa. So we're going to measure the slide and the measurement of the slide. So how much is the vertical and how much is the horizontal component in the slide. So I'll put a leaf gauge in there. So close your teeth. Grind it forward, move it forward and back and squeeze. Can you feel that tooth? Perfect. So now we know that this is the first point of contact, which is CO. Now what I tend to do is, if you just keep it like that, I check the reference point. You can obviously assess this on the model much easier, but if you want to see this in the mouth, you would check the reference point. So I will use this premolar nice tip and I will use a probe like that and then gently open a tiny bit and close, and you can see how much movement it has happened and how much vertical and how much horizontal. So once again, open again, close your teeth, grind forward and back, and squeeze. You feel that too? Perfect. And open them gently, and close. And you can see the reference to the probe, how much the teeth have moved. Open again, close your teeth, grind it forward and backward, and squeeze. Feel the tooth here. Gently open and close, and you can see the slide. And that's what it suggests, that there is a more horizontal slide than the vertical. That means the jaw moves forward more than the upward, as far as you can see, or maybe 50-50, which is a very big slide. So you learn how to do occlusal examination using some of the protocol which I have developed. In the next video, you will learn how to implement the knowledge of occlusion into day-to-day clinical practice.